Hamilton. And I will go ahead and call the meeting to order. We will do roll call by county, starting with Boise County.
Commissioner Stern, present.
Thank you, Ryan. Valley County.
Mr. Hasbrook, present.
Thanks, El. Elmore County.
Representative Blanksma, present.
Thanks, Megan. Ada County.
Jane Young here.
Ted Epperly here.
Mr. Lachiondo here.
Okay, thank you, folks. Okay, proceeding on with our agenda action items. Russ, do we have any changes to the agenda we need to address?
Madam Chair, no changes to the agenda this evening.
Okay, thank you. Under new business, the first item of business is review of the COVID-19 metrics for criteria for determining quarantine and restriction orders for Ada County by Kimberly Link, Communicable Disease Control Manager. So, Kim, the floor is yours.
Thank you, Madam Chair. And Dustin, if you could pull up my slide set, please. Perfect. And so the first slide that we're starting with is the one that's titled Central District Health Ada County Criteria Summary. This is our high-level overview. And from the information that's been updated since last week, looking at the trend information, we have seen an increase in ICU and non-ICU admissions among Ada County residents. Our disease reports have overall trend-wise increased, although last week we did see a slight decrease in the number of cases reported. We are still seeing high numbers of cases being reported on a daily basis. We did have 3 days last week, they were non-consecutive days, where we had over 100 cases reported among Ada County residents. And in terms of the clusters that we are keeping an eye on, those are remaining very similar. So Boise State, Department of Corrections facilities, Ada County Jail, and we do have 2 more long-term care facilities that have active outbreaks that are going on. So we're monitoring 27 active outbreaks in long-term care. And if you could go to the next slide, please. So as we look at the hospital criteria, this top section, again, is looking at non-ICU admissions. On the left-hand side, you can see over the past 4 weeks, we have had a distinct increase going from single-digit admissions among Ada County residents to now consistently being in the high teens and 20s. As we look on the right-hand side of this top section of the page, this is our 2-week trend line, and you can see that that is indeed an upward trend in the non-ICU admissions. And if you can scroll down to the next set of graphs. This next section includes ICU admissions. We don't see as stark of an increase in the number of admissions, but as you can see from the trend line on the right-hand side, we are seeing a slight increase in the number of ICU admissions. And I think that's visible as well as we look over the past 4 weeks where we were in very low single digits in September and now are pushing upwards of 8 to 10 admissions on certain days at this point. The bottom sets of graphs include information about the hospitals that are here in Ada County and their total number of patients who have COVID based on ICU and non-ICU. And you can see, again, fairly similar trend as we're looking at this, with non-ICU admissions seeing a slight increase and ICU admissions showing an increase as well, although not quite as high as what we've seen with the non-ICU. And in the next page, please, Dustin. So this is the page titled Disease Criteria. This top section, it looks at our Ada County confirmed and probable cases by day of report, so including all residents of the county. And you'll see that we did have a number of days, like I said, 3 days last week, where we surpassed 100 cases being reported among Ada County residents. As we look at that trend line, you'll see it's definitely flatter than what we saw in last week's report, although there is still a slight upward trend. And if you can go down to the next set of graphs. So the next set of graphs, the portion that's on the top part of the page right now includes Ada County residents, but it takes out inmates from the Department of Correction facilities. And you'll see that these numbers really for last week did not change very much. We did not have a whole lot of positive tests being reported out of corrections. So when we look at our trend, it is very similar to what we saw when we're looking at the county as a whole. And as we look at the bottom graph, you can see a little bit more clearly that that difference in the number of cases being reported last week. So we were just shy of 700 cases among Ada County residents, 820 the week prior. One thing to note with the testing from the week prior, that does include about 100 inmates coming out of Department of Corrections. So as we look at, again, that level of illness within the larger community, those numbers are very similar over the past 2 weeks. And if you can move to the next slide, please. So on this slide here, we have, this is the one titled Ada County Case Rate and Emergency Department Syndromic Surveillance Information. You'll see on the top graph that this is our average daily case rate per 100,000. This past week, our case rate was at 22.49. This was a slight increase over what we had seen the week prior. And in terms of what we're looking at for school categories, that does put Ada County in the category 3 or red category. And if you can move down to the next set of slides, or the next set of graphs, we have the 4-week emergency department visit graphic shown on the bar graph. And this includes people who are going to emergency departments with the symptoms of fever, cough, shortness of breath, and they either did not have flu testing performed or they were negative for flu, so a COVID-like illness. And as we look at this over the past 4 weeks, and as we look at the 2-week trend on the right-hand side, you'll see that those numbers are remaining fairly stable. And as we look at the bottom graph, that's our emergency department visits since really the beginning of the pandemic, and our visits as of late have increased a little bit since what we've seen in September, but over the past couple weeks have remained fairly stable in the 40s for number of visits over the course of a week. And that is my formal report. I'm happy to take questions.
Okay, thank you,
Madam Chair.
Yes, who's speaking, please?
Sorry. Thank you, Betty Ann. This is Diana.
Okay, go ahead, Diana.
So I'll just preface by saying, one of the things I think that's so important about these meetings is to make sure that we can get the questions out that we're getting in this open forum. So Kim, I know you've had these questions from me in the past, but I'd appreciate you answering them so that the public can understand what we are seeing and hearing. First one is about the surveillance testing at Boise State. So Boise State is now doing surveillance testing, which means they're testing asymptomatic people, which is good. That's a good thing to be doing. But of course, that does mean we'll have more positives. One of the things I'm continuing to try to understand, and I didn't quite get an answer from Boise State on it on this call this morning, was whether the folks who are turning up positive, many of them are living in off-campus apartments. Are they just hanging out with each other, or are they going home to perhaps parents or grandparents? And I think we all know that those are two different scenarios that could lead to two different outcomes. So I haven't heard anything new on that, but Kim, did you have any information you wanted to share?
Madam Chair, this is Kim.
Yes, go ahead.
Okay. Commissioner Latiando, I don't have any new information as far as any significant differences in trends in what we've been seeing. I think that we see a spectrum of activities among young adults who are testing positive for COVID, where many of them are spending their isolation period at their apartments or their homes with their housemates and roommates. Others are living at home, so isolating in the presence of their parents. Regardless of what their situation is, we always do make sure that we're talking with them about what safe isolation looks like so that we don't have further exposures within the household setting. I think the one thing that I would add on top of that is that over the past couple weeks, we have seen a decrease in the number of Boise State affiliated individuals testing positive for COVID, so seeing fewer students. I know that they are going to be starting larger scale surveillance testing, and that definitely has the possibility to increase the number of positive tests that are coming out of that student population. I think as we look at that and as we're made aware of perhaps students who are testing positive, who are asymptomatic, if those become large numbers, that would be something that I think would be very important to share with this group so that there's a full understanding of how different types of testing are impacting our data.
Thanks. If I may, I have one more question, then I'll let somebody else have a turn.
Go ahead.
Dustin, could you pop back up the cases, that the graph that shows the positives and the probables? And I'll just kind of talk you through what I'm thinking if you're not able to pop that up. Great. So that's what I'm looking at. I've had folks asking questions about probables, and they are wondering what that means. And I don't want to put words in your mouth, but you can confirm or deny what my thinking is here. My understanding is that as we've had a lot more antigen testing of late, we have more that are initially placed into that probable category. And then those folks need to go get a PCR test after that. Could you explain how those different tests get categorized?
Sure, Madam Chair, this is Kim.
Yes, Kim, go ahead.
Okay, and that's a great question, and I know that understanding the different types of tests and the case status is something that has been, I think, challenging throughout the entire of the pandemic. As we look at people who are classified as having a probable case status, they can have that through one of a couple ways. Originally, we were looking at people who were a close contact to a person or to an individual who had tested positive by PCR testing. Those folks are called classified as confirmed cases. So you have that close contact who then goes on to develop a standardized set of different signs or symptoms. Say if they develop a fever and a cough, then they would be classified as a probable case. And we use national case definitions to determine whether or not their signs and symptoms would meet that case classification. Additionally, now that we have antigen testing that's becoming more prevalent, people who are going out to get tested and test positive on antigen testing are being classified as probable cases. If they do go on to receive PCR testing, which some do and others do not, if they receive that PCR testing and they're testing positive, they would go on to have their case status changed to being confirmed. When we look at if they test negative on PCR, that situation gets a little bit more foggy as far as what happens to them in terms of their case classification, just based on that timing between when they tested positive on antigen testing versus when they went to get that PCR result. So by and large, yes, you're correct in what your assumption was in terms of looking at case classification.
Okay, thank you, Kim. Anybody else have questions for Kim?
Madam Chair, this is El.
Chair.
Yeah, I think Elt was first. Elt, go ahead.
Well, I can go last. I don't mind.
Okay, Megan, go ahead.
Thank you, Madam Chair. I just wanted to ask a question of Kim. How are you doing on splitting out those the corrections numbers in the folks that are incarcerated full-time versus those that are actually interacting on their with their community on work release or that type of thing? Have you been able to split those out?
Madam Chair, this is Kim.
Yes, Kim, go ahead.
We do track, when we're looking at corrections, we do track what facility an individual is incarcerated at. So that's not information that we're necessarily putting out onto the dashboard. However, it is information that we're tracking in different ways so that we have an idea of how many are incarcerated full-time versus those that might be part of community relief centers.
thank you, Kim. Elt, you want to go with your question for Kim?
Sure. Thank you, Madam Chair. Kim, I'm trying to figure out, because, you know, we've heard in the past that about 40% of the people that are exposed to corona are asymptomatic. That means they don't get sick, they don't come in. How do you account for those in your numbers? I mean, maybe we have a higher population that have been exposed and gotten through this than we're really, and we don't have any way to count them. How do we, I don't know how to ask the question, but how do you account for those, that 40% that got through it?
Madam Chair, this is Kim.
Yes, Kim, go ahead.
I think that is a question that is being grappled with nationwide, truthfully. We know that asymptomatic testing is not widely available at this point within our health district. There are some labs that are offering it, but by and large, many people can't necessarily just walk into a physician's office and say, hey, I think I've been exposed, I don't have any signs or symptoms. So I think we don't necessarily know what we don't know. When we have individuals who are getting tested asymptomatically, we're making note of that information. I will say that there are many instances where a person may go in and get tested after an exposure, say at day 2 or 3 post-exposure, and they may be asymptomatic at that time. However, by the time that we reach them for interview another day or 2 later, we find that they are developing signs and symptoms of illness. So I think it's difficult to get an idea of how many people are truly asymptomatic for COVID versus those who may be pre-symptomatic or have mild symptoms, such as maybe just a runny nose. So I think that's something that we're going to continue to try to do our best to gather accurate and as full of information as we can.
Thank you, Kim.
Betty Ann, this is Ted.
Yes, Ted, go ahead.
Yeah, Kim, couple thoughts and then a question for you. Clearly, we continue in the red zone with numbers greater than 20 per 100,000. You showed that again this week. And we know that from one of the graphs you showed on the probable or the case under disease criteria that our numbers continue to be high, well above 332 back in September, growing to 820 week before last, right at 700 this week. So we clearly have an uncontrolled spread in the community still. It's our third spike. We kind of recognize that. Temporally, that's associated because there's really no totally clear ability to say why, but temporally it's associated with return to school, K through 12, colleges, universities. But I recognize that temporal association doesn't prove causation. And it's one of those perplexing things about this right now is, what do we do? How do we try to get this as clear as possible, as right as possible with data so that we can best both educate the community and make the right decisions? So with that, I've heard you say last week that contact tracing in schools is difficult. And I totally get that. It really is. But for us to try to understand the potential for schools with this, because none of us want to close down schools if we don't have to. Absolutely not. We want kids going to school. We want them being educated. So knowing, and I want to update Elt a little bit, he had said it's up to 40% asymptomatic. In kids less than 19, it's as high as 79% asymptomatic. So my question to you, Kim, saying all of that, understanding we've got a community spread, understanding the temporal association with school, what are the thoughts that perhaps you and Russ have had, the internal team at Central District Health, about doing asymptomatic testing at a middle school, and a high school, just so we can try to get the data clear here on, what percent of the class asymptomatic may be COVID positive, both at middle school and high school. We don't need, I don't think we need to take a look at elementary schools as much, but middle school and high school. What are your thoughts about using some of our resources to try to answer that question?
Madam Chair, this is Kim.
Yes, Kim, go ahead.
Well, Dr. Epperly, I think that's a great point to bring up, and it looks like Russ had to step away for a moment, unfortunately, because I think a lot of this goes into the policy realm of the work that we're doing. As we look at being able to get a better understanding of what's going on in our school settings, being able to have that surveillance type testing, I think is going to be important to get a better idea of the full picture. As we look at testing in a school setting, I think that one of the main challenges that we would face is looking at the parental consent portion of it. I don't think that that's necessarily insurmountable. It's something that we have worked through in providing vaccines in the school setting, but I think it would be something that would be looking to CDH leadership to look at how we would make that come together, if that's something that within our staffing we were capable of taking on, and if that's something that Russ from his perspective was wanting to look at as far as our direction in terms of CDH response.
Okay, Russ, are you back enough with the conversation to be able to respond to that? There might be something else going on here. Russ, can you hear me?
He have his earphones on. He can't hear you.
Yeah. Okay, it looks like he's preoccupied.
Okay, this is Betty Ann. Does anybody else have a question for Kim while we're waiting for Russ to come back on?
I did have one more question, Kim.
Actually,
Did I hear Megan?
yeah, I actually did have a question. I think it's related to what we're talking about here, in that I'm getting information back, and I guess I'm just trying to find out if it's accurate or not, Kim. I'm getting information back from different sources that, including a text today, that they're hearing from schools that it's, quote, difficult to work with the health districts to get funds when it comes to testing dollars. Do you have any information on that, or am I best served to talk to Russ about that later?
Madam Chair, this is Kim.
Yes, Kim, go ahead.
I think that is a question that's probably better served to Russ, as I'm not as in the loop on that side of things.
Thank you.
Okay. Did I hear somebody else speak up previously?
Yeah, Madam Chair, this is El.
Yes, El, go ahead.
So this is maybe more a question for Dr. Epperly. I'm not really sure. But it seems to me like if 79% of the kids up to 19 are asymptomatic, we need to figure out a way to get all those kids tested. And that's going to take a lot of the stress off the schools to know that if they've got, I don't think you want to call it herd immunity, but if a great majority of those kids are asymptomatic or have already gotten the disease and gotten over it, maybe we're making an issue bigger than it needs to be. Am I wrong on that? Does that make sense?
Yeah, it makes a lot of sense, Eld. What we're both saying is that we just need to have clearer data. Knowing that there can be a lot, and especially the younger the child, the more asymptomatic they are, we could have a whole lot going on in the schools that we're just not aware of because of the asymptomatic situation. And as Diana said, many of those kids could then go potentially home and spread it to adults or older adults, grandparents, et cetera. So I just think that if we have the resources, and Russ, I can see Russ is busy with something. I hope it's not serious there in the building, but the situation, I think, is that if we had the resources to do some asymptomatic testing or what we call surveillance screening, maybe we could choose one or two high schools, one or two middle schools, get what the data is. I think we can make better decisions about what and how to respond. It could help us a whole lot, because right now, and I'll stop with this, we're in the dark. We're trying to do the best we can, but we don't have the data to be able to make a call on this that is in the community's benefit. And I think that's the frustration of this for many of us. I know it is on the medical community side. And I'll stop.
Okay, thank you. Russ, are you back on?
Madam Chair, we have a few issues going on. I think it's under control, but we have some folks in the room, as you might be able to hear in the background, not willing to wear face coverings per the board's policy set last Friday. So we have Boise City Police here, and they're working on the situation right now. So it might be a little bit difficult for me to talk, but I'll be on when I can.
Okay, thank you, Russ. Now, there was a question directed to Kim.
That was me.
I'm sorry.
Oh, sorry. I'm sorry. I had another question, but maybe you want Russ to ask Megan's or answer Megan's question.
Okay, go ahead, Diana.
So a different topic, but one that I'm paying attention to. So as we look at the data, Kim, related to ICU admissions, hospital admissions, we have learned through the course of this that our limiting factor is not necessarily physical beds. It is staff capable of taking care of people. And that's where we were in a real bind back in July. So I don't see us there yet locally, but I am paying attention to the fact that statewide we have the highest number of ICU admissions since the beginning of this pandemic. And I think this is maybe more of a question like a homework assignment for you or Russ. I don't know what the staffing plan looks like if Eastern Idaho Regional Medical Center gets overwhelmed and run out of staff, or if St. Luke's Magic Valley is overwhelmed. Are those folks coming here? This is something we're trying to grapple with, and it's again become kind of trite to say we're all in this together. But I don't think those patients are going to get punted over to Montana. So I'm wondering if you have an answer to that, or if that's sort of a homework assignment we need to understand.
Madam Chair, this is Kim.
Yes, Kim, go ahead.
Commissioner Latiano, I think that is maybe a bit of a homework assignment, and I'm happy to work with Russ, our preparedness partners, and our hospital partners to get a better understanding of what that situation looks like. I know that our hospitals here in Ada County do receive patients from all across the state and from other states as well, depending on the level of acuity of their illness. So from my understanding of the healthcare system, I do think that there is some potential of seeing patients from other areas of the state being hospitalized here in Boise. I think just as part of the regular medical care, but I think the question of what that looks like in surge situations is a good one, and it's one that I'm happy to work with Russ to follow up to get a better idea on.
Thank you, and I bring it up because when I was on the receiving end of a call from Dr. Burks back in July, her concern for Idaho was that if we have a combination of rural spikes plus high level of disease in our metro center, that's where we're maybe going to be in a bad shape. So that's why I asked.
Megan?
Madam Chair, this is Representative. Thank you. Yeah, actually, I have some information on Eastern Idaho, and that I had talked to somebody over there, and a lot of those patients, when they become severe enough, are going to Utah. They're not routing them this way. They go to Utah.
Right. Correct. Okay, thank you. Any further concerns or discussion for Kim before we move on? Okay, hearing none, we will move on to number 2 under our action items under new business, discussion and possible vote if the board wants to review and approve recommendations that CDH provides to schools regarding their operational plans to include such topics as in-person learning and extracurricular activities prior to such guidance being issued. Russ, would you like to lead this discussion, please?
Sure. Again, I'd be glad to. Hopefully the background noise won't be too disturbing. So I just wanted to quickly kind of go over some of the history and the process that we've gone through during the pandemic as it relates to schools. The document that Dustin just pulled up on the screen gives the basically the responsibilities for each of the various organizations noted here, with local public health district being in section 2, is we have two responsibilities in the back to school framework. And this is a state issued document. It was provided by under the signature of Governor Little on July 9th. So that was about the middle of summer. And it is guidance and best practices. And we do basically 2 things. One is to identify categories of transmission within the community, which we've done, and then to advise local education agencies on operation and health and safety plans. So with that, we started right before the school year normally started in late August for all schools within our public health district. Is we started with some guidelines that were put together by the Department of Health and Welfare, by the state, and then we updated those guidelines on September 4th to simplify the guidance. And that was just so it'd be a lot easier for the public to understand when we would move between the 3 different categories of green, yellow, and red. And as Dr. Epperly mentioned earlier, the red category that we chose at the time on September 4th was to say 20 cases per 100,000 per day over a 2-week period of time. So that's where we got to. So according to the guidance, and again, it's just guidance from the State Board of Education was very involved in the development of that as far as the operational plans. It's still left up to the local school boards. That's who ultimately makes the decision on how they operate, from in-person learning to extracurricular activities. That's where the decisions are made. But we do provide advice, just like we have really since April of last year. So with our school recommendations, knowing as we were moving into the red category, it was the week of October 5th when we could see that being very likely for the following week to be the school category designation being red for Ada County. We started communicating with our schools. We have a close relationship with all of our schools, again, all 4 counties, although this is specific to Ada County, letting them know we were very likely to go to red. But based on what we're seeing in our communicable disease control section, we have made the decision with the well thought out school plans for in-person learning, and the fact that we were not seeing much or any transmission occurring in the schools. Again, that doesn't mean we don't have cases in schools. We have students with COVID, we have had teachers with COVID and other staff, but the real point with this is, could we continue with in-person learning? So that's what we chose to do with our specific recommendations, was to go ahead and support schools continuing with in-person learning. We did ask them to pause as far as their reopening schedule. Some schools started with, maybe K through 3 and then 4th through 6th grade, and rather than continue to open for in-person learning was to slow that down. And then the second part of that, which again, Kim could speak more to as far as the data, is we recommended pausing extracurricular activities where there was close prolonged contact and the inability to wear face covering. So that's obviously high risk. So again, that's our role. So we issued that again well ahead of the week, which was the week of the 12th. With the 12th being a holiday, so we issued a red designation on the 13th. That's all the schools were informed. We released this to the media that Friday so that the public would be aware. And again, this has been what we do, but certainly if the board wishes to be more involved in those types of decisions, then we'll certainly accommodate that. So that was the point of this agenda item, was to have that discussion, as you noted, Madam Chair, and I'll be happy to answer any questions and take direction from the board.
Okay, thank you, Russ. Any discussion or questions for Russ?
Madam Chair, this is Elt.
Yes, Elt, go ahead.
I don't know. I'm beginning to feel like, we've done everything we can to warn the schools, to warn the public that this is a serious situation that we're all dealing with. And we're catching a lot of heat for things that the school boards have instituted or are doing. It's really not our issue, our fault. I think as long as we stay ahead with the data and we can prove that there is a problem in the schools and it's in the extracurricular activity, and let the schools handle that, I think that's the only way we can proceed. If we start coming out and saying, nope, you can't do football, you can't do basketball, you can't do a lot of this stuff, it's going to turn around and bite us pretty hard. Just my feeling.
Madam Chair, this is Representative Blanksma.
Yes, Megan, go ahead.
Thank you, Madam Chair. Just a comment, not really a question for Russ. I think that Elt is 100% right. I think this is a case of staying in our lane. We were elected, then eventually appointed to these jobs to talk about public health issues. I don't know that we're an authority on how to run a school. I think that the state board has done an excellent job of trying to work out the best possible plans. And I think that it's important that the health district continues to review the data and continues to provide recommendations, but the local boards need to be responsible for their school districts. And I've talked to multiple medical professionals over the last couple of days, including one who was recently on Channel 7, who is volunteering his time with the school districts to help develop plans and help develop auditing processes. And so I think that, and he also is in agreement with this plan forward of provide the advice, provide the information, and then the local districts need to add in the additional information they have. Kids that don't eat unless they go to school, kids that are on special plans and need extra assistance, kids that may have abusive situations at home. All of those should fall into the concerns that the local district decision-making model should have. And I think that the community transmission determinations by Central District Health are a good piece of that, but it's a piece of the decision-making that the district needs to make. And so I'm 100% with ELT. We need to provide the best data and the best recommendations we can, but in the end, those are the elected officials that are meant to run that school district.
Thank you, Megan. As chair, I'm in full support of ELT and Representative Blanksma's position on this. So, any further discussion on this matter?
Yeah, Madam Chair, this is Ted Epperly.
Yes, Ted, go ahead.
I'm 100% in support as well of what ELT and Megan said. but there's a nuance to this that I think we need to also be sensitive and aware of. And that is, I think, I really agree with our role here is to gather the data and make recommendations around public health that the schools can then take and consider. My angst with the particular situation where we made the recommendation around allowing in-person education to continue, although I think given in good faith, I think what that created was almost permission by some of the school districts, one in particular, to basically make the old yellow the new red, meaning that they could continue with a hybrid learning model in the red zone. And again, I'm not trying to be critical nor find fault here, but I think it was probably beyond our call, beyond our recommendation ability to say that we make the recommendation to proceed with in-person training. It gave implicit permission, I think, to the schools to do that, and that created confusion. It created potential loss of trust. It created some role conflict from staying in our lane. And so my only thought that I would add to this is that if the recommendations might get into a strategic realm that would change the back to school framework that the school board has set, then I think that ought to be something we really consider. So with that's my concern with this particular issue. And I'll just summarize by saying our job is to collect the data, analyze the data to the best of our ability, make recommendations about public health. But I think it's not our call to advise them on continuing or not in-person education. That's their role. And that's where I think we might have overstepped with the recommendation.
Madam Chair, this is Diana.
Yes, Diana, go ahead.
So I'm in agreement with much of what's being said. We're all in a sticky situation. I'd like to shift the conversation just a little bit. And, obviously we've all heard from teachers, we've heard from parents, especially in the West Ada School District. Everyone is concerned about their kids. They're concerned about the health and safety of their students. I think we need to sort of shift the conversation a little bit. And really, this is, people are sick of hearing us say this, but this is about the community. This is about lowering the level of community spread so that kids, teachers, families, everybody are in a better position. So, and there's evidence out there. I think it was reported today, I heard on NPR, that New York City, a city of 8 million people, is having a lot of success in getting kids back to school, but they are doing surveillance testing and they have really low rates of community spread. So for me, the question is less about schools, although it is important. I'm hearing all those things, but how are we going to lower the rate of community spread so that schools are in a better shape, hospitals are in a better shape, et cetera? What are those levers, Russ? And I think that's where we're kind of struggling at this point because everybody's sick of this, but it's still happening. So do you have any suggestions about that or thoughts?
Madam Chair, I'm sorry, I had to get up and work with the security here, so I did not hear the question. If you could repeat it.
Diana?
Sorry, I'll make it shorter. So, we're in a position where we're, in that red level for schools because of a rate of community spread. And, unfortunately, this is really tearing our community apart right now. And instead of pointing fingers back and forth within the school component, I think the larger question is, how do we lower the rate of community spread. And I want to put schools and kids at the very top of the list of things that we prioritize alongside our healthcare systems. So what are the levers that this board could discuss to lower those rates of spread?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
You know, that's a great question, one that's often discussed here among our staff. And with the face covering mandate for Ada County in place and for Valley County, you know, that's one of the really good steps we've taken. Of course, compliance varies throughout our community and depends on which business or social gathering. You know, there's photos that are sent to us and stories that are shared with us in our call center where people are blatantly, in my mind, it's blatant when you know this works and it's requirement of the Board of Health. So that needs to be stepped up, in my opinion, that people need to follow the orders as they exist today. What are the next steps? You know, I think it's really going to depend on where we're seeing community spread. Where we're seeing community spread right now, the transmission is occurring when somebody gets it and then they take it to their home, they take it to their family members, they take it to relatives. So it has to do a lot with areas where it's very difficult to control. It requires on people's goodwill to protect the health of the community. So we're not seeing problems in a specific grocery store, for example, or other retail outlets. Where we're seeing most of the community spread is occurring in the household and family context. And again, Kim is on and she can explain that in more detail. I don't have a specific recommendation at this time as far as what we can do next. What we're doing here at Central District Health is we're very closely monitoring the situation we see going on within our health systems. I think that's critical. That's what we've talked about all along, is protect the vulnerable population and keep our health systems from getting overwhelmed. So, you know, right now, our health systems, and I'm talking here in Ada County, not other parts of the state, where they are starting to have some serious challenges. But at that point, then you start rolling back further with more blanket approaches like what we saw at the beginning of the pandemic. I'm not sure we're going to have any other options if our hospitals get to the point where they can't provide care, not only to COVID patients, but anyone else who might need it. And that's the concern we're trying to avoid. Obviously, we don't want vulnerable population, the elderly, for example, to get this disease because of the serious consequences. So we still have to think about that, which is the next topic on our agenda.
Okay, thank you, Russ.
Betty Ann, this is Ted. If I can ask Russ a question.
Yes, go ahead, Ted.
Thanks, Russ, for that. I think you guys are doing a great job. I really do. You and your operational staff, you're to be commended really publicly for this. You know, and if this was easy, would have this sorted out a long time ago. This is complicated and there's a lot of moving parts. Russ, a question that I'd framed a little bit earlier, now that you're back, is part of the confusion here, because we're all trying to do the best we can, is to sort out the data to the best of our ability so we can stay in our lane, make the right call in regards to the data of transmission and also our recommendations around public health related to the data. Since, again, up to 79% of people less than 19, a good published data report, can be asymptomatic. That's a whole lot of kids. I was wondering earlier, Russ, so we can try to clarify the data, is what do you think? Do we have the resources? And would pose this to Kim too. She wanted you to weigh in on this, to do surveillance testing of asymptomatic kids in middle school and high school. Perhaps I'm just thinking here, we've got roughly 40 schools in West Ada that would fall into, or in Ada County that would fall into this. Could we pick a couple middle schools and high schools and surveillance test and try to get some degree of feel of positivity around coronavirus, COVID-19 here, in asymptomatic kids so that we could have data to make a better informed call. So your thoughts about that? I recognize we may not have the resources, but what do you think about that in this situation?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
I think if we had the resources, I think that would be helpful to help us better understand what's going on in our communities. But as you know, as a healthcare provider yourself, the ability to obtain the lab testing capability for technology that is accurate for asymptomatic individuals, pre-symptomatic individuals, is simply not available. We've been at this for 7 months now in Idaho. Had our first case on March 13th here in our district in Meridian, and we're still having challenges with available testing technology. And to be honest with you, it seems like every time there's a new idea, like Binax Now comes out, and that was really to be focused on school staff, teachers, and students. But it's not recommended for asymptomatic individuals because you get false negatives, a real high percent of false negatives. So with that, you end up having this picture that really doesn't help us any more than what we have today. So I do like the surveillance idea. Obviously, if we were to try to do 70,000 students plus all the associated staff with schools, that would far outstretch our capabilities, even if we were to test no one else. So I like the idea. I think it's something our staff needs to continue talking about. It is something we have talked about, but it's just the lack of access to accurate testing, accurate and timely, right? Quick turnaround time technology, which allows us to do our primary job of isolation and quarantine.
Betty Ann, just a quick follow-up. Thank you, Russ, for that. Please continue to talk about it. We don't have to do all of them, but just maybe a targeted 1 or 2 middle schools, targeted 1 or 2 high school if we could, because this will get back to Diana's point around lowering rate of community spread. If we know that piece of data, then we can more effectively weigh in on the impact potentially to adults in the community, teachers, parents at home, grandparents of kids that are asymptomatic. That's my whole point. And I recognize if we could have done this, we would have done it. And I recognize now the question is, can we potentially target a couple in a way that might give us data enough to then make an informed decision? And I'll stop.
Okay, thank you, Ted. Any more comments on this issue?
Madam Chair, this is El.
Yes, El, go ahead.
I'm sitting here thinking about this and trying to remember my college classes on this kind of stuff, but it seems to me like the only way we're going to really get on top of this is to dial it down on who is asymptomatic and who isn't. And is it a matter of money, Russ, that we don't have enough money to do this, or is it a matter of there's just no tests out there that can do that?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yeah, Commissioner Hashbrook, it's definitely not a matter of money. The resources are simply not available. If you look at the testing availability, even in your county, like with Cascade Medical Center, we provided a Abbott rapid test machine, which actually is a PCR test technology, so it's very accurate, but it's just that constant bottleneck with the supply chain. And same with St. Luke's McCall. I don't know what their current protocol is, but in many instances our health systems are doing pre-surgery testing or symptomatic testing, but they're not doing widespread routine testing for asymptomatic. And that, again, like I said, our governor is very interested in making sure our schools are able to do their jobs, have kids back in school, and to continue with the extracurricular activities, but the resources aren't available. The money's there, the resources aren't available.
Thanks, Russ.
Okay, thank you, Russ.
Madam Chair, this is Jane. I had one question.
Yes, Jane, go ahead.
So if we took one of the scenarios and you did the surveillance testing and you found out that there was what percent, can you go on with what you would do with that? I'm not sure who I'm asking, but maybe Dr. Epperly.
Well, I'll take the first stab at this quickly and let Russ, the expert, weigh in further. If the asymptomatic rate in a pilot or targeted middle school or high school was 60%, Jane, then I would think that you would not have in-person education going on at that school. And the reason is that serves as a huge source of infection into the community. And it would be best to quarantine those kids, middle school and K through 12, so that we control the spread. If we don't know that and we allow asymptomatic kids at high percentages to continue intermingling in the community, it's going to be almost impossible to get this under any degree of control in the next 6 to 8 months. And that's the concern. So if we don't know what we don't know. If we don't look, we won't know. Russ, I think, is right. Testing availability is an issue. Testing accuracy in asymptomatic kids is a problem. So we're stuck kind of between a rock and a hard spot on this in knowing what to do and what we know. I'll make one last comment, and that is contact tracing in schools is unbelievably difficult. We won't know, like we did with the bars, if the schools are responsible for a large outbreak. It's just too difficult to track, especially with a lot of asymptomatic. So we have no clue what we're really in for here with all the schools continuing with in-person. It just becomes a total chaotic quagmire.
Any further comments before we move on? Okay, hearing none, if there's no more discussion, we will move on to action item number 3 under new business, which is a discussion of potential vote regarding actions to protect the life, health, and safety within the district as to the COVID-19 pandemic, to include potential amendments to current public health orders for Ada County and consideration of orders that include the opportunity to visit residents at long-term care facilities. Russ, would you like to comment on this before we open the floor to everybody else?
Sure, yeah, thank you, Madam Chair. So last Tuesday, a week ago today, we had a discussion about modifying the Ada County orders, because it only applies to Ada County within our 4-county health district. The restrictions that prohibited visitors to long-term care facilities. So that was under the Ada County orders, and I'm pulling it up here on my screen. The section, basically it's item number 6 is where it was noted that visitors to long-term care, Ada County Jail and State Correctional Facilities are prohibited. So what we did at the board's request was we removed the long-term care facilities from 6, so they're no longer prohibited, put them under section 7, and section 7 is now visits to long-term care facilities are allowed based on the following parameters. So I won't go into all the detail. I know the board has a copy of this document. The public has a copy of the document. It was posted on our website. There are a lot of restrictions, and the restrictions are put in place to try, to the best of our ability, to keep staff from introducing the virus and keep the residents from contracting the virus. Now, we've done that, but now we're introducing a new population, which will be visitors. So we used the Centers for Medicare and Medicaid Services guidelines to put this together. Thanks to my staff for taking the time to make sure we didn't leave anything out. Again, it's consistent with the federal guidance on visits to long-term care facilities. So there was a couple of questions or points that I wanted to make and ask the board as we're discussing this, but just to give you some perspective of what this looks like. In Ada County, we have 99 residential long-term care facilities that includes 15 skilled nursing, which leaves the about 84 assisted living. So it's a significant number. There's a lot of families that have been affected by the order, but again, that is the most vulnerable population starting at the beginning of the pandemic, and it remains the most vulnerable population today. So I guess I would look for direction from the board as far as if you want me to go through this in detail, or if you want me just to point out a couple of minor changes that I've made since the draft was posted, and then there's a question for the board as well.
Okay, thank you, Russ.
Madam Chair.
And I do have a
Madam
question
Chair.
for you before we get started. The surveillance testing conducted on staff, have you revised that to be more specific? We know that most of the COVID is coming in via staff on a frequency basis. Do you have a comment on that?
Sure, Madam Chair. So it's in the CMS guidance, and that's something that we could actually put directly in the order. So the 15 skilled nursing facilities that I mentioned here in Ada County, they are already required to follow specific guidelines where and it's based on positivity rate for the county, not within the facility. So Ada County right now, as published on the CMS website, is just under 10%. So there's low, medium, and high is how they describe it. Less than 5%, 5 to 10, and then greater than 10%. And that dictates the frequency. So again, it's not related to that specific facility, but the testing requirement for staff would be based on those risk categories. At the low level, it's once per month, and at the high level, greater than 10% positivity, which is at least according to CMS, we're close to that, is twice per week. And then, you're definitely going to have challenges with testing availability for these folks, just like everyone else in the community. But so we could either put it in the order or just refer to that as we're working with the facilities.
Okay. Thank you, Russ. Megan, I heard you speak up.
Thank you, Madam Chair, for a motion. I just want to, I applaud the speed and diligence with which these were drafted, and I'm willing to put a motion on the floor to accept the changes in the draft orders, and then we can go from discussion there if somebody's willing to go for a second.
Okay.
Madam Chair, this is Jane. I would second it.
Yes, Jane. Did you second it?
Yes.
Okay. Thank you, Jane. Okay, the motion has been made and seconded to go ahead and approve this long-term care and assisted living draft. Is there any further discussion before I call for a vote?
Madam Chair, this is El.
Yes, El.
The way I look at this, and you guys tell me if I'm wrong, but it's no different than the way we treat the schools, or we treat, all the bars, all the different industries, is that here's the risk. If you can come up with a plan and make it work that we think is appropriate and acceptable, then we accept the plan. We have to leave this up to other industries to solve their own concerns. And I think Russ did a marvelous job, and his staff getting all this stuff together so fast. And like Megan, I thank you, Russ, for doing that. We're fortunate up here. We've only got like one facility in the whole county for this, and they've done very well so far. So I just think we got to treat it the same as we do all the other different industries.
Madam Chair, this is Diana.
Yes,
So I have been the recipient of, I know Russ has as well, both families who are frustrated that they haven't been able to see loved ones. And that's, I'm really glad that we're putting this together. And I want to echo Representative Blanksma for your thoughtfulness and speed. I think the question I have is, we have varying degrees of maybe sophistication and adherence to guidelines across the county in no matter what industry someone's in. And if our number one goal is protecting the vulnerable and subsequently not overwhelming the healthcare system, and we know that this is a huge nexus right here. Do you have thoughts about sending in CDH staff who I know are already very tapped to review how things are going? Is there some other organization that we can ask for help with? Is like the state, licensing bureau, health and welfare? I don't know. I just know that this is such a critical population for both of those goals.
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Yes, Commissioner LaChionda, we've actually been working with all of our long-term care facilities and skilled nursing facilities. Really, I keep saying since day one. I wouldn't say exactly on March 13th, but not long after that. We have staff here who are dedicated to working directly with the long-term care facilities throughout our health district. And you're right on the staffing and resources. That's definitely a limitation, but it's something that we're definitely committed to doing and committed to doing long term. So, where a lot of our help has been around, helping them understand the guidelines, helping them implement it, and then also helping them through situations where they have staff who test positive for COVID, or in instances where the residents test positive for COVID. So if that's something the board would like us to do, as far as helping them review their plans, do site visits, we can figure out a way to make that work on some basis.
I know hiring is always a challenge, right? We're trying to get that through, but I think this would be money well spent and resources well spent toward both of those goals for those, plan reviews, which you're already doing, but also stress testing. I think that's the term that we've heard some physicians use out in the community. Had different eye coming in, and stress testing systems sometimes can lead to new insights versus the person who put it together. So I would be supportive of that.
Okay, thank you.
Madam Chair, this is Ted.
Yes, Ted.
Yeah, thank you. Russ, just for the good of the public listening, could you just do a high-level, quick summary of what the changes are? What would this look like to a skilled nursing facility or an assisted living facility in terms of visitation, so that the public understands what it is that this would change?
Sure, I'd be glad to do that, Madam Chair.
Yes, Russ, go ahead. Okay, thank you.
So what would it? I'm sorry.
Who's speaking, please?
I'm sorry, Madam Chair. This is Russ. I was going to respond to Dr. Epperly's question.
Oh, okay. Go ahead.
So high-level overview of what this would look like. Many of them, in fact, probably most of them, are doing some of this work, which is really, but it'd be focused on the residents and the staff. Now we're going to expand it to visitors, where screening all who enter the facility for signs and symptoms. That can include questions, observations about signs and symptoms, and then, of course, not allowing entry into a facility if, in fact, someone has a fever or has a cough or sore throat or other symptoms associated with COVID. Hand hygiene, face covering requirements, physical distancing. And again, that's more of what you would call the things that they're already doing. But when you start with visits, in our orders, for example, we say outdoor visits must be given priority, because we want people to be, if they're outside, we know in open air, it's less likely to be transmitted. So that would be given priority. of course, we recognize we're heading into fall and winter, and there may be also the health of residents might not make that possible. So there's also other factors. There has been no new onset of COVID cases in the last 14 days among staff or residents, and the facility is not currently conducting outbreak testing. So I can't remember what the latest number is. Kim would have it. I think we have maybe 27 of the facilities who have current, active cases going on. So visitors to those particular facilities would not be allowed at this time. Facilities limiting movement of visitors within the facility. So this wouldn't be anybody, show up with a family of 10 and move throughout the facility. The idea is to limit the number of visitors, allow them access to their family members, physical distancing, face coverings required, and possibly, limiting the time that they're within the facility just to allow others to have that same opportunity, right? Because you want to control the number of people who potentially could introduce COVID into the facility. So that's kind of a high level overview of what this would look like.
Thank you, Russ.
Thank you, Russ. We do have...
Madam Chair, this is Russ.
Yes, Russ.
I'm sorry. I did have, there's 3 things I wanted to cover very quickly before you guys vote, if I could.
Yes, go ahead.
Okay, so under section C, which is under 7, section C, there's facilities must limit movement in the facility. So I added, it goes on to say, for example, visitors. So I just added of visitors just to make that crystal clear. That's what we're talking about, limiting movement of visitors. So I'd like to add those 2 words, of visitors. Then under section D, facilities should use the COVID-19 county positivity rate found on here's the words that would be added, the Centers for Medicare and Medicaid Services COVID-19 nursing home data site. So all of our nursing long-term care facilities are familiar with this, but I just wanted to add the Centers for Medicare and Medicaid Services just to make it crystal clear where that data source is. Then the third item, which is really the big one, the one for you all to discuss, is we're saying if positivity is greater than 10%, visitation should only occur for compassionate care situations. And that is directly from the CMS guidance. What I would ask you, are you comfortable with should? This is an order. Should is a recommendation. You want that to continue to remain as should, or is that the kind of the gating limitation for whether visitors are allowed or not, is if we had a positivity for the county on the CMS website of greater than 10%. That's what I have, Madam Chair.
Okay, thank you.
Madam Chair, this is Representative Blanksma.
Yes, Megan, go ahead.
So as the maker of the motion, I would accept the first 2 changes, but I want the final, I want the visitation to continue to say should. So if my second would agree, that I would be willing to make the first 2 changes in support of the order change.
Okay, that was Dr. Young seconded the motion. Dr. Young, are you okay with those amendments?
Yes, I am. All 3.
Okay, thank you. Okay.
Madam Chair, this is Ted. I just want to clarify something with Russ on that.
Yes, go ahead, Ted.
So, Russ, with the 10% positivity, is our should that nursing homes, then skilled nursing facilities, assisted living, will make the call on visitation? That's the should, that they will have the ability to make a judgment call on that versus a hard no if it's greater than 10%. Is that, am I correct?
Madam Chair, this is Russ.
Yes, Russ, go ahead.
Dr. Epperly, that is exactly correct.
Okay, just wanted to make sure.
Okay, thank you. Okay, hearing no more voices raised, the motion has been made and seconded as amended. I will call for a vote by county, starting with Boise County.
Commissioner Sturm, aye.
Thank you, Ryan. Valley County?
Commissioner Hasbrook, aye.
Thank you, Elmore County?
Representative Blanksma, aye.
Thank you, Megan. Ada County?
Jane Young, aye.
Thank you, Jane.
Ted Epperly, aye.
Diana?
Commissioner Laciando, aye.
And Ted, did I hear you speak up also?
Yes, Ted Epperly, aye.
Okay, thank you. Okay, motion passes unanimously, and many thanks for pulling this together, Russ, you and staff. This is a huge issue. Okay,
Madam Chairwoman?
that brings us to the end of our agenda today under action items.
Madam Chairwoman?
Yes, Megan?
I've got your motion ready if you're ready.
Well, we have no further items on the agenda, so I guess
Madam-
we are ready.
Madam Chair, this is
Okay,
Jane.
motion to adjourn.
Jane?
I had a quick question. On number 2, we never did a vote, did we?
There was never a motion made.
And I'll second.
Madam Chair, this is Elt.
Yes, Elt?
I know this is not on the agenda, but I would like to ask Mike Kane if he's heard anything more about our letter that we sent to the Attorney General as far as who controls our funding and our decisions as a board. Have you heard anything yet, Mike?
Madam Chair, can you hear me first of all?
Yep.
Yes.
About a week ago, I spoke to Brian Kane, and he says they're working on it. He described it as a tough question, and there was a lot of law books open, and that was about a week ago.
Thank you, Mike.
Okay, thank you, Mike. Okay, we had a motion for adjournment. Was there a second to that motion?
Commissioner Sturm, second.
Okay, thank you, Ryan. Any further discussion before we adjourn for the night? And Russ, before I call for the vote, what is going to be the date for our next meeting? I want the public to know.
Madam Chair, the date for the next meeting is going to be Tuesday, October 27th at 5:15.
Okay, thank you so much. Okay.
Betty Ann, this is Ted. I just want to make sure Jane's voice was heard. Jane, are you comfortable with a no vote on number 2, or are you suggesting we return to a motion and action? Jane?
Madam Chairman, point of order.
Yes.
I was trying to get past this, but a motion to adjourn is non-debatable, so we need to vote on the motion. So if we want to go back on the agenda, you need to vote no on the motion to adjourn and then go back and pick up an agenda item if somebody wants to make a motion to vote on that.
So, Madam Chair, this is Ted again. I want to ask a question to Jane. Jane, are you satisfied? Yes or no?
Yes, for the moment. I don't feel like we stuck to the issue and came to a consensus, but I understand now that it needs to be a motion.
Okay, thank you.
Okay, Jane, did you refer also to the rules and responsibilities in the code number here that Russ provided us? The authorities and the roles and responsibilities? I think that helped me.
I'm not sure what you're talking about.
There's in our packet, there's a sheet with roles and responsibilities of various boards and districts, and it cites the code numbers.
Right, I understand that. I felt like it was still sort of up in the air if we were going to be recommending to the schools or how that was going to go down. So I'm fine with waiting and see if it comes up at the next meeting.
Okay. All right, well, we'll go ahead and call for a vote on the motion to adjourn then. I think we got as far as Ryan and Elt. Megan, Elmore County?
We didn't
Elmore
vote,
County.
Betty
Oh, I'm
Ann.
sorry. I thought we did.
No,
Okay,
we just,
Boise County.
I seconded the motion and yet I vote aye.
Okay, Valley County.
Mr. Hasbrook, aye.
Elmore County.
Representative Blanksma, aye.
Ada County.
Jane Young, aye.
Ted Epperly, aye.
Diana.
Diana Laciando, aye.
Okay. Okay, folks, the meeting does stand adjourned, and thank you so much for your input and participation. And I do thank the public for their interest and the emails that you are sending to us. So, next meeting, as Russ announced, will be next Tuesday, October 27th at 5:15. So, good night, everybody. Okay, good morning. This is the Central District Board of Health meeting for Friday, August 21st. It is 8:30 in the morning. I will introduce myself as the presiding chair.